of Umul Al-Fatihah. Dear all participants, please fill in the Google form for the star points via link provided. Today we'll be having our speaker, Dr. Fitra Hanani, to speak on upper gastrointestinal bleeding. Without further ado, I would like to invite our speaker to start the session.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, so you don't need to call me doctor, just call me Akak. I'm just your senior. Okay, so today, boleh start ke? Okay. So before we start, okay, Alhamdulillah sebab kita masih bagi peluang untuk menghadiri majlis ilmu. So tak semua orang terpilih lah untuk menghadiri majlis ilmu. So pagi ni Alhamdulillah Allah masih bagi kita kesihatan untuk teruskan berpuasa dan untuk menghadiri majlis ilmu pagi ni lah. Okay. So our topic today, I'll be discussing about the upper GI bleeding. Okay, nak present slide. Okay, so for today's topics, so it is upper GI bleeding. Sebelum saya start present, kalau ada tersekat-sekat ke ataupun internet saya tak stable, tolong kasih tahu ya sebab internet saya kat rumah ni dia on off sikit stability dia. So kalau ada apa-apa soalan nak tanya ataupun tak faham tengah-tengah saya present, boleh stopkan saya kalau ada sangat. Lepas tu kalau nak tanya soalan boleh juga tanya dalam chat box, nanti lepas present saya akan entertain. Okay, so let's start. So our topic was upper GI bleeding. So next, before we start learning something, you need to know what you are going to learn. So this is the content of my presentation today. I'll be discussing with you about the approach to upper GI bleeding, which is including the history, physical examination, also investigation, and I will be briefly describe to you the management of upper GI bleeding, which is include the non-varicose bleeding and also varicose bleeding. Okay. So let's go to approach to upper GI bleeding. So when we see approach to upper GI bleeding, we need to know what to ask in the history, what to elicit in the physical examination, and what investigation should be done. So there are four main things that we need to emphasize when we are going to approach to upper GI bleeding. So the first one is to support or confirm your diagnosis. The second one, to rule out differential diagnosis. The third one, to assess the risk factor or etiology of the disease. The fourth one is to look for complications of the disease. So these four things need to be covered in these three categories. So for the history taking, the first thing that we need to know for upper GI bleeding, we need to know what are the symptoms and complications for the upper GI bleeding, and then we must differentiate: is it varicose bleeding or non-varicose bleeding? Okay. So just I mentioned just now, so there are four things that need to be covered. Okay. So in the history, eventually you need to practice on not moving. Reading view kan? So, setakat mana tadi? Okay, apa? So this is the content I mentioned just now. Okay. So this is the approach of upper GI bleeding, what to ask in the history, physical examination, and also investigation. So the four things that need to be emphasized in this three categories. Okay. So for the history taking, we need to know what is the symptom and complication of upper GI bleeding, and we must differentiate between varicose and also non-varicose bleeding. So we approach by these four things also. Okay. So in the history taking, we need to practice to use the momentum so that we don't sound awkward when tracking patient in front of the doctors. Especially sekarang kan syllabus baru, so kita kena plug patient tu depan doctors in 10 minutes and then present later on. Okay. So So waktu 10 minutes tu tak perlu pun nak ask in details yang sangat-sangat, tapi the most important part kena ask in detail. Okay. So this is the diagram that you need to map in your mind during tracking session with upper GI bleeding. Okay. So first for the upper GI bleeding, for the symptom and complication, what to ask the patient. So patient presented with hematemesis, melina or hematochezia. So when patient presented with hematemesis, we need to ask in detail of the complaint. So hematemesis, we need to quantify the amount, the duration, the frequency of the hematemesis itself. And then you need to ask if patient having melina, which is complaint of black stool, or hematochezia, which is indicating the massive upper GI bleeding. And then for the complication part, you can ask the anemic symptoms since the patient is bleeding. So you can ask from head to toe. Just remember from head to toe, is patient having dizziness, standstill, chest pain, shortness of breath, or palpitation. Okay, that's the common symptom that we ask. Okay. And then you initially when the patient came to us, so we club a stable patient. So in the history taking, you need to ask the patient during the presentation at the emergency department, how was the patient? Is he conscious or unconscious? So if the patient is unconscious, we might think that the patient is hypovolemic shock when he arrives at the ED. Okay. So we must further differentiate the upper GI bleeding. Is it non-varical or varical bleeding? Okay. For the non-varical part, you can further divide it either it is a benign or malignant. So for the benign, this is the common differential diagnosis, which is peptic ulcer disease, esophagitis, menorrhagia vestae, coagulopathy, and then for the malignant part, it is either gastric or esophageal cancer. Okay. For the varicose bleeding, the most common causes are chronic liver disease. Okay. So what are to us in this distinction and also diagnosis? Okay. So for the most common you can get in your exam is peptic ulcer disease. So for the peptic ulcer disease, you need to ask the patient. As I mentioned just now, when you want to approach to upper GI bleeding, we need to confirm the diagnosis, we need to rule out the differential diagnosis, and we need to assess the risk factor and also complication of the disease. Okay, so if peptic ulcer disease is the most probable diagnosis, you need to ask in detail regarding the complication of peptic ulcer disease. So from this slide, I just include the most common presenting symptoms, the risk factor of the disease in order to rule out the other differential diagnosis. Okay. So for the peptic ulcer disease, you need to ask patient ni pernah ada history of gastric tak before, and then kadang-kadang patient tak tahu dia ada gastric. So kena tanya dia ada tak macam experiencing frequent epigastric pain. Okay, and then the factor of UGIB tu memang kena korek betul-betul lah dengan patient. Kadang-kadang terlepas pandang. Okay. So risk factor dia adalah chronic NSAID injection. Okay, selalunya makcik-pakcik dia selalu dah complain of macam sakit betul. Lepas tu dia akan keep on ambil NSAID over the counter. So dia memang banyaklah consume NSAID tu memang in chronic, dalam chronic punya NSAID injection dapatlah upper GI bleeding. So ataupun patient tu memang ada ambil frequent aspirin, which is antiplatelet. Okay, ataupun patient ada H. pylori infection. Okay, yang ni tak boleh nak tanya direct lah. Ada tak H. pylori infection sebab patient pun tak tahu apa tu. So kalau H. pylori infection ni kita boleh detect kalau patient pernah presented dengan upper GI bleeding before, and then dia ada buat test waktu scope, and then doktor ada kata lah kat dia yang dia ni ada H. pylori infection. Lepas tu dia kena ambil waktu discharge tu doktor bagi kat dia triple regime. Okay, triple regime ni nanti akan brief lepas ni. Okay. Triple regime ni dia ambil ubat tu dia kena makan untuk 2 minggu. Okay. Selalunya patient akan ingat lah kalau ubat tu makan dalam 2 minggu. Okay. Lepas tu kalau esophagitis, apa kita nak tanya? Kena tanya patient tu ada tak dysphagia, which is and then ataupun jet lag symptom macam acid blush ataupun heartburn. Okay. For the menorrhagia vestae boleh tanya juga patient tu sebelum dia dapat menorrhagia vestae tu dia kena ada frequent vomiting. Okay. So frequent vomiting lah menyebabkan retching of dia dekat gastroesophageal junction tu menyebabkan tear. Okay. So ataupun kita selalu lupa nak rule out lah coagulopathy ni. So jangan lupa tanya dia briefly, tanya pasal bleeding tendency, any bruising, any gum bleeding ataupun patient on anticoagulant. Okay. So for the gastric esophageal cancer, kita boleh tanya lah early symptoms of this cancer, which is early satiety ataupun constitutional symptom. And then risk factor tu just tanya eating, ada tak macam suka tak eating salty food ataupun ada family history of cancer before. Okay. For the varicose, which is the common cause of chronic liver disease, you need to ask the risk factor of chronic liver disease. Ataupun kalau patient tu dah memang ada masalah hati, sebenarnya dia dah tahu lah, dia tak masalah hati. Memang kita suspect lah, mungkin ada variceal bleeding lah kalau dia memang dah ada underlying chronic liver disease. Okay, kalau tak ada lagi, just ask the risk factor for CLD. Which is ada tak history of blood transfusion, lepas tu patient is IBD or alcoholic. Okay. So tracking skills require practice, practice and practice. So no one can be perfect when they are the first time tracking patient with apa je bleeding ke ataupun dengan apa-apa case. So tracking skill ni memang perlukan practice sebab itulah dia memang practice supaya korang boleh lah tahu apa kekurangan korang kat mana, nak baiki kat mana. Okay. So keep on practicing on how to track the patient. Okay. So let's proceed to physical examination part. Okay, so in general, approach dia sama je for things that need to be emphasized. Okay. Kalau general patient tu datang, tanya dia conscious ke tak waktu tu, sebab kita nak tahu patient tu in shock ke tak. And then kita tanya, the most important part to assess if the patient presented to us with in acute setting adalah vital signs. So note if the patient is hemodynamically stable or not. Okay. And then kita tengok pallor or jaundice, since patient bleeding, so kita expect dia akan pallor lah. Okay. So kalau untuk jaundice and stigmata chronic liver disease ni, kita nak rule out lah patient tu ada chronic liver disease ke tak. Okay. And then if patient is cachexic ataupun virtual not liver, mungkin patient ada gastric or esophageal cancer. So suspect. So kita kena check juga CCTVR. Ini dia ada early signs of shock. So kalau baca CCTVR ni akan tahu apa CCTVR ni. So kalau CCTVR ni dia adalah color, capillary time, temperature, volume and rate of the pulse. Ini memang kena check lah patient, kena assess CCTVR ni, kena tahu patient tu in shock ke tak waktu tu. Dia boleh jadi compensated shock, kita tak tahu. So abdomen, kalau per abdomen ni kita tengok abdomen tu distended or not. Distended ni selalunya dalam chronic liver disease cases. So kita selalunya dia distended sebabkan dia ada ascites. Okay. So kalau dalam peptide ulcer usually kita akan jumpa tenderness dia kalau per abdomen. Okay. And then for the mass, kalau dia dah selalunya cancer dah late sign lah of cancer. Selalunya tak apa-apa pun kalau early gastric or esophageal cancer. Okay. So kita kena complete lah patient presented dengan apa je ni, kena complete with digital examination. It is to look for Medina. Okay. So this is the signs of chronic liver disease, memang kena hafal systematically. So hafal in systematic way lah, macam mana korang buat abdo examination, hafal ikut turutan. Macam kalau abdo examination kan korang suruh patient macam mula-mula tu tolong buat tangan macam ni. Lepas tu check lah for any clubbing, lepas tu check for any acidic, lepas tu check any palmar edema, deposit contacture, lepas tu pergi dekat lengan, tengok ada tak signs of risk factor for CLD which is IVDO, ataupun ada macam complication of CLD, boleh pergi macam dia ada bleeding, ada bruising dah dekat lengan dia ni. Lepas tu pergi dekat mata, tengoklah pallor jaundice. Lepas tu pergi tengoklah ada berjas nak kebal ke tak, ada spider nevi, lepas tu ada guide inkomersia ataupun loss of hair, and then kaput medusa. Maksudnya korang go sini, doctor akan suka lah kalau korang present, kalau korang, sebab selalunya short case, kalau in short case korang tu kena present on the spot, which is running commentary. So waktu korang describe je, non ini memang laju je describe. So selalulah practice dengan kawan-kawan supaya describe in a systemic way. So investigation wise, so this is the table that was included in the CPG. Okay, what investigation should we do when patient presented with upper GFBD? So there are two ways of dividing how we want to divide the investigation, how to present the investigation to the lecturers, what investigation that we want to do. So the first way, the first method was we need to go through the four things that I emphasized just now. This is what investigation should we do to support or confirm our diagnosis, and what investigation to do to rule out the differential diagnosis, what investigation should do to assess the risk factor or etiology of the disease, and what investigation should we do to look for complications of the disease. And then the other method, we can divide either into blood investigation, bedside investigation, imaging, or specific order. Okay. And then for the in-surgical, akak suka divide according to blood, bedside imaging, and specific lah. Sebab senang nak cakap flow. Sebab kadang-kadang investigation untuk support diagnosis, untuk rule out differential diagnosis, dia kadang-kadang bertinggan. So macam susah sikit lah kalau nak present. So dalam surgical skill lah, akak suka approach by blood, bedside imaging, and specific. Tapi dalam medical pun kadang-kadang guna juga approach ni. So ikut keselesaan korang lah nak guna method yang mana. Okay, so for the blood investigation, I would like to do full blood count, glucose measure, coagulation profile, NF profile, liver center and ABG. And then untuk setiap investigation yang korang cakap ni, korang kena tahu kenapa korang nak buat benda tu. And then what is expected result from this patient. Okay. So contoh nak buat full blood count untuk tengok apa? Tengok to look at the severity of the anemia in addition to HBD. So kita suspect HBD ni memang low lah. So glucose measure nak buat untuk apa? So glucose measure ni kita buat sebab patient might need blood transfusion. So buat glucose measure, urgent blood transfusion. Okay. So kalau coagulation profile, kita nak tengok patient tu ada coagulopathy or not. So lah coagulopathy punya problem. Okay. And then for the ataupun patient on anticoagulant lah, kita tengok INR dia berapa. Okay. So kalau in the profile kita tengok sebab patient akan bleeding. So patient might have acute kidney injury. Okay. So for liver function test, it is to rule out chronic liver disease lah. Okay. So for the actual blood gases, you need to kena tahu dalam sebenarnya apa je IBD, dia akan dapat hypoponic shock. Okay, so hypoponic situation ni dia orang akan dapat metabolic acidosis. So how hypoponic shock ni akan lead to metabolic acidosis? So bila reduce in circulatory blood volume, so badan kita akan jadi hypoxic. Ada tisu yang tak dapat oksigen, dia akan jadi hypoxic. So reduce in tissue perfusion. Bila reduce in tissue perfusion, dia perlukan oksigen to continue the respiration. So badan dia akan convert aerobic respiration tu kepada anaerobic respiration sebab dah tak ada oksigen. Okay, sebab dia pun kena survive, so dia akan buat anaerobic respiration. So bila buat anaerobic respiration akan menyebabkan metabolic acidosis. Okay. So bila kat work tu, korang try lah practice untuk interpret this common investigation with your friends. Sebab korang tengok je blood result patient tu, discuss terus lah. Okay, this is blood count, patient ni, patient is anemic. So with leukocytosis, kena belajar interpret. So macam laju je bila nak exam tu. Okay. So kalau untuk bedside ni tengoklah patient tu indicator tak nak buat DXP, ECG misalnya 40-year-old underlying DM ke, kena buatlah DXP, ECG. Okay. Kalau imagine chest X-ray, selalunya dalam practice after this memang kita buatlah chest X-ray sebab tak tengok apa, kita takut patient tu develop complication of PUD which is perforated PUD. So kita nak tengok apa, air under diaphragm. So spesifik kita buat OGDS lah. Yang kena dalam kes ni spesifik sebab nak tengok ulcer, nak tengok any oxygen dependencies. So this is the chest X-ray showing air under diaphragm. So for the management, so let's go to the management of non-varicose bleeding first. So akak suka divide sama ada in acute setting and in ward management. Soalnya kalau dapat apa je bleeding cases in exam, so lecturer akan tanya sebab kita kan dapat patient yang dah stable. So soalannya selalunya bunyi macam, okay, if you are the first doctor to see this patient in emergency department, how would you manage this patient? Okay, so soalnya management ni memang hafal lah. Apa je macam mana nak approach untuk satu cases yang common untuk masa exam. Okay, if I were the first doctor to see this patient in emergency department, then I would like to initiate resuscitation measures. Okay, which is I would like to support airway, breathing and oxygenation of the patient. Okay, and then since the patient is bleeding, I would like to resuscitate patient with fluid. Okay, so bila resuscitate patient with fluid, kalau korang tahu detail and korang yakin dengan korang punya ilmu lah waktu tengah exam tu kan, korang boleh cakap detail kalau patient is in hypovolemic shock nak buat apa. Macam I would like to insert flash probanula and I will give Twistloid, IV Twistloid, 0.9% normal saline, which is 1 pint over 10 to 50 minutes. And then I will recheck the vital signs, which is the BP, the heart rate, okay, and then to look at the patient improving or not. And since I have given the patient fluid, I would like to monitor the input-output check. If necessary, I will insert the CBD to the patient. Okay. Itulah tadi punya macam overview lah kalau korang nak cakap pasal secure airway breathing circulation dalam apa je FBD ni. Okay, so and then if it is a non-varicose bleeding, I would like to insert nasogastric tube, which is to prevent aspiration pneumonia. Okay. And then I would give patient IV pantoprazole at the empty site. Okay. And then I would like to send patient for urgent endoscopy by following the algorithm in the CPG. So akak akan discutkan lepas ni algorithm in CPG. Okay. So in ward management, kita go through that dulu. Okay, so kita pergi algorithm, ni algorithm management dalam CPG of non-varicose bleeding. So bila patient presented dengan acute upper gastrointestinal bleeding, okay, and then first kita kena resuscitate lah patient, and then risk assessment. Okay, risk assessment ni akak akan terang sekejap lagi. Dia guna Walker score. Okay. And then kita akan send patient for endoscopy within 24 hours. Okay. Uh, kita akan resuscitate patient dulu until patient stable. Tapi kalau selagi patient tak stable, walaupun dalam lepas 24 jam, kita kena stablekan patient dulu sebelum kita send patient for endoscopy. Sebab kalau kita send patient, unstable patient to endoscope, dia akan lagi worsen the patient condition sebenarnya. Okay. So the most common adalah peptic ulcer. Common of non-varicose adalah peptic ulcer. So bila kita scope, kita akan jumpa ulcer. So bila kita jumpa ulcer tu, kita akan classify ulcer according to Forest ulcer classification, which is dia ada major stigmata of recent hemorrhage atau minor stigmata of recent hemorrhage. Okay. So jom kita go through Forest ulcer classification jap. Okay, so this is Forest ulcer classification. Dia ada 1A, 1B, 2A, 2B, 2C and also 3. Okay. So each classification dia boleh indicate how many percentage the patient might have bleeding post endoscopy. So these are the easy number lah to remember. Like for example 1B, patient might have 50% of bleeding post endoscopy. Okay, and then so this is the picture of Forest ulcer classification that you might see during endoscope during OGBS. Okay, so grade 1A, you can see this is spurting black. 1B is oozing black. What 2A is non-bleeding but visible vessel. Okay, kalau 2B dia ada clot. Okay, kalau 2C dia ada hematin base, which is macam merah-merah, dia merah macam and then for the 3 dia ada clean base, which is heel ulcer lah. Okay, itu untuk forest ulcer. Okay, so forest ulcer ni kita kan dah divide into major ke minor stigmata of recent hemorrhage. Okay, so bila dah major dia 1A sampai 2B. Kalau minor 2C, 3. Okay, kalau kita jumpa patient tu adalah major stigmata of recent hemorrhage, so apa kita nak buat next? Kita akan buat endoscopic hemostasis ataupun nama lain dia adalah dual therapy. So ni adalah choices for endoscopic hemostasis dalam CPG. Okay. So dia ada 3 method, which is thermal, injection, also mechanical. Okay, the most suggested adalah kombinasi, dia panggil dual therapy sebab kita akan guna 2 method daripada 3 ni. Wajib guna waktu patient ada major stigmata of hemorrhage. Okay. So kalau untuk combination therapy, CPG suggest kita better guna injection dan also chemotherapy. However, kalau waktu akak praktis dekat HTA dulu, diorang suka guna injection dengan mechanical therapy, which is diorang akan inject adrenaline and also diorang akan guna endoclip, which is mechanical method lah. Okay, so kita dah bagi endoscopic hemostasis and kita pun kena bagi juga IV PPI punya infusion for 72 hours. Okay. So kenapa kita bagi 72 hours? Okay, so in ward management tadi IV tentu kita akan bagi 8 mg per hour for 72 hours for activation to take place. So stomach kita kan dia ada epithelial lining. Epithelial lining tu perlukan masa 3 hari untuk dia fully break balik lah, protect the stomach lining. Okay. And then lepas bagi IVPPR macam biasa dalam ward kita akan monitor patient punya vital signs and then kita akan go for risk reduction. So depend patient tu what are the develop apa jadi. Kalau sebabkan NSAID, so kita akan patient from consume NSAID tu. Okay, so and then kalau disebabkan oleh H. pylori infection, kita kena eradicate lah H. pylori tu. Kita akan eradicate patient tu if necessary. Okay. So kita akan discharge patient ni dengan tablet PPI for 6 weeks. And then for 6 weeks juga kita akan TCA kan patient tu. Masa follow up tu dalam 6 minggu and then kita scope balik patient. Sebab kan kita nak tengok ulcer tu dah heal ke belum. Okay. So ni adalah triple regime therapy yang Kak mention untuk eradicate the H. pylori infection, which is dia ada PPI, which is pantoprazole ataupun omeprazole, and dia 2 types of antibiotic, which is dia bagi amoxicillin ataupun clarithromycin. Kalau patient tu allergic dengan amoxicillin, penicillin base, kita akan bagi dia metronidazole dan tidak amoxicillin. Okay. So kita akan bagi preparation ni for 2 weeks. Ada source yang kata 10 to 14 days. So about 2 weeks lah. So bila patient kita dah bagi dah endoscopy emergency, IVPPI, and then no bleeding, yang tadi lah step yang kita akan buat. Kalau patient ada re-bleeding balik lepas kita dah bagi endoscopy emergency after IV infusion PPI tu, kita akan repeat balik endoscopy emergency tu. Okay, kalau sukses, teruskan step tadi. Kalau dia fail, kita akan tengok patient tu dia good surgical candidate ataupun poor surgical candidate. Kalau good surgical candidate, kita akan go for surgery. Kalau dia poor surgical candidate, kita akan ni lah request for interventional radiology, which is kalau kat UAE tu for Fazali lah. Okay. And then kalau untuk major stigmata of hemorrhage, kalau patient ada minor stigmata of hemorrhage, which is forest 2 or 3, kita akan terus go for risk reduction atau ADKH kalau okay. And then patient tu boleh early discharge lah. Okay, that's for management. Ini work score, which is risk assessment for non-varical. Sebelum kita scope patient tu, kita akan buat risk assessment, which is worker score, which is dia ada komponen age, shock, status, comorbidity, post-endoscopy answer atau hemorrhage. So kalau untuk pre-endoscopy, kita akan dapat tahu 3 ni je lah, age, shock status and comorbidity. So dan seperti saya cakap, kalau patient tu point dia 2 or less, maksudnya dia adalah low risk patient. Patient can have early discharge lah. So ni adalah algorithm management of acute variceal bleeding dalam PPD. So kat rasa diagram ni complicated sikit, so akak dah summarize lah. For the management of variceal bleeding can divide in acute setting, for the prophylaxis management and also long term management. So in acute setting dia similar dengan non-variceal bleeding. Okay. So kita akan resusc patient. So resusc nak buat apa? Kita akan sama tadi tu ABC, co-ABC, and to assess patient, monitor vital sign, insert CVD, monitor input output chart. However, dalam variceal bleeding, never insert NG tube if variceal bleeding is suspected. Okay. Sebabkan kita akan induce more bleeding to the patient, precipitate the bleeding. So bila kita insert NG tube kan dia akan erode dia kita punya oxygen. And boleh jadi salah puncture dia varices ke, nanti more bleeding akan lagi severe. So kalau dalam severe bleeding, dalam variceal bleeding, kita akan insert sense-sucking Blackmore tube instead of NG tube. So sense-sucking Blackmore tube ni, dia punya function, dia banyak function lah. Jadi korang boleh tengok lah sebab dalam procedure, korang kena tahu dekat indication dia apa. Tengok doktor suka tanya, tapi tak ada lah perlu tahu in detail. Okay. And then sense-sucking Blackmore tube ni, dia kita boleh prevent expression pneumonia. At the same time, kita boleh stop the bleeding sebab dia ada extra balloon yang dekat catheter dia tu. Okay. However, walaupun kita dah insert sense-sucking Blackmore tube to stop the bleeding, dia hanyalah temporary measures only before kita go for definitive therapy. Okay. So pharmaco adalah pharmaco paling banyak lah nak kena bagi dalam variceal bleeding. So ni adalah list pharmaco yang kita kena bagi kat patient yang presented with variceal bleeding. So kalau dalam management of non-variceal bleeding tadi, kita bagi IV pantoprazole, kita bagi IV pantoprazole ATMG tag kan. Okay. So kalau dalam ni, dalam variceal bleeding kena tambah lagi IV boxpeptic antibiotic, selalunya bagi LV ceftriaxone 1 gram OD. And then kita bagi juga IV vitamin K sebab patient yang CLD dia ada coagulopathy. Kita bagi vitamin K. And then kita bagi vasopressor. Okay. Vasopressor ni dia boleh banyak lah jenis boleh bagi. Okay. So dalam CPG mention IV somatostatin ataupun octreotide, tapi SPA diguna telepressin. Okay. So apa function vasopressor ni dalam variceal bleeding? So vasopressor ni sebenarnya dia punya function adalah untuk inhibit the release of glucagon. Okay, glucagon ni dia punya function adalah untuk vasodilatation of the gut punya blood vessel. Okay. Dia akan promote vasodilation in the gut. Okay. And then kita akan bagi vasopressin. So vasopressin ni dia akan inhibit glucagon release. So bila inhibit glucagon release, indirectly dia akan inhibit vasodilatation of the blood vessel in the gut lah. Okay. So basically nak kata kita bagi vasopressin supaya blood vessel in the gut tu vasoconstrict. So dia akan reduce in bleeding lah. Okay. So untuk pharmaco, and then kalau untuk definitif kita ada 3 punya method. Sama ada kita buat endoskopi, OGBS tadi, kita buat sclerotherapy ataupun variceal bending. Okay. And then second kita boleh kalau first tak jadi, kita go for tick. So ni adalah dia punya flow lah. First kita buat OGS, which is sclerotypy atau variceal dulu. Kalau juga CBD, kita akan buat tick, which is intrahepatic position. Okay. And then the kalau tick saya juga kita akan go for open lah, immunization. Okay. And then for prophylaxis management, kita boleh divide into primary atau secondary prophylaxis. Okay, kalau untuk primary prophylaxis ni, dia ada certain patient yang indicated for primary prophylaxis. Okay. And then, beza primary prophylaxis dan secondary prophylaxis ni, kalau primary, selalunya patient tak pernah presented dengan variceal bleeding. Patient ada chronic disease contohnya, tapi dia tak pernah dapat variceal bleeding. So kita nak prevent that bleeding from happening. So kita panggil dia sebagai primary prophylaxis. Kita mencegah lebih awal daripada dia berlaku. Okay, kalau untuk secondary prophylaxis tu, patient pernah presented dengan variceal bleeding. And then kita nak prevent from happening again in the future. Kita nak prevent from recurrency lah. So untuk prophylaxis ni kita akan bagi patient beta blocker. And then kita juga akan buat variceal banding lah, which is band ligation. Okay. So kenapa beta blocker kita bagi, sebab patient kan ada oesophageal varices. So oesophageal varices ni dia memang adalah dilated cautious vein kan. So kalau untuk beta blocker ni, kita dekat biopsy gitu tu kan kita belajar ada alpha dengan beta receptor. Okay. So, kalau alpha receptor tu fungsi dia adalah untuk vasoconstrict. Kalau beta receptor fungsi dia adalah untuk vasodilate. So kita bagi beta blocker, maksudnya kita prevent the blood vessel from vasodilate. Okay. So kita basically kita vasoconstrict the vessel lah, untuk kita prevent dia from bleeding. Okay. So kalau untuk long term management pula, kita depend on the specific lah. Kalau patient ada underlying chronic liver disease, kita treat accordingly by that disease. Okay, so ni classification of oesophageal varices. Kali ni kita akan guna Japanese classification. So dia ada grade 1, 2 and 3. Okay, kalau grade 1 ni boleh tengok dalam gambar ni for the F1 tu. Di grade 1 dia adalah small straight varices. And then for the F2 ni dia adalah medium varices, which is dia dilated tapi tak adalah tortuous. And dia occupy less than 1/3 of the lumen. Okay, kalau untuk F3 tu dia adalah grade 3. Dia adalah large varices, which is memang dilated, tortuous. They occupy more than 1/3 of the lumen. Okay, so patient yang macam mana yang indicated for primary prophylaxis? This is patient yang ada grade 2 and then dia ada endoscopic red signs. Okay, endoscopic red signs ni lah endoscopic red signs. Korang tahu je lah, endoscopic red sign ni exist. Tak perlu tahu in detail pun tak apa. Okay. So kalau patient yang ada grade 2 and ada endoscopic red signs ni ada indicated for primary prophylaxis. Grade 3 ni, grade 3 je dia terus indicated. Tak perlu ada syarat apa-apa. Okay, so tu je lah rasa untuk apa UGIB approach and little bit management about varices and also non-variceal. So important message for you to take note. So it is good for you to practice your classing skill, also communication skill lah. Sebab we can get 70% of diagnosis from the history taking. So it depends how good your classing skill and how good your communication skill to get to the diagnosis. Okay. And then you need to know the what and why. Okay. Selalunya third year, waktu third year lah doktor suka lah tanya soalan what and why ni. So macam contoh dalam history taking ataupun PE ataupun investigation lah. Okay. Dalam history tu contoh dalam soalan apa korang tanya patient. Okay, soalan apa yang perlu tanya and kenapa korang tanya soalan tu. Selalunya doktor akan suka lah tanya. Lepas tu kalau PE pun sama. Kenapa korang buat, apa yang korang buat tu and kenapa korang buat. Okay. So kena tahulah apa yang kita buat tu. Jangan sekadar examination, lepas tu tak tahu nak examine nak tengok apa. Okay, and kenapa nak tengok benda tu. Okay, selalunya kena tahulah. Third year memang banyak soalan macam ni. Sebab third year doktor tak go sampai ke management. Selalunya sampai ke investigation dulu. Kalau sampai ke management tu doktor tanya principle je selalunya. Principle of management. Okay. Sebab tu dia banyak soalan what and why ni. Kalau final ni doktor dah expect, dia dah tahu dah what and why ni. So doktor akan proses je sampai ke management. Okay. So kalau dalam waktu korang buat work tu, it is good for you to have buddies lah. So buddy to practice the PE and discuss cases. So sangat bagus lah sebab waktu korang di ward, takkan korang bawa buku yang tebal-tebal kat bilik tu kan. So korang akan apply the knowledge korang, ilmu yang korang ada dalam kepada korang je. Maksudnya it is to train your memories on what you have read. Okay. So waktu praktis PE ke, korang buat je flow, body korang tu boleh timing masa, boleh tengok apa yang tertinggal. Nanti dia boleh tegur lah lepas pada habis korang punya buat PE tu. And then korang boleh juga discuss cases. So aku rasa discuss case ni memang sangat bagus lah, especially waktu kalau korang selalu praktis daripada third year lagi, memang lagi dah bagus. So final year tu memang kena discuss cases je kalau kat work tu. Sebabkan bila kita discuss case ni, kita akan lagi networking of our brain tu memang bersambung lah. Sebab senang, sebab kadang-kadang apa yang kita fikir lain dengan apa yang kawan kita fikir. So kita boleh match that thoughts tu, lepas tu and then come to conclusion lah what are going on with our patient. So aku akui memang dalam medical field ni korang rasa stres yang sangat-sangat. Tipulah kalau tak stres langsung, alah relax lah. Medical pun, macam tu lah. Selalunya memang akan ada lah stres tu, sama ada orang stres belajar, ada orang sebab peer pressures, ada orang family, ada orang financial issues. So lain orang tu lain orang uji dia punya kesusahan. Okay. So macam mana kalau korang stres tu korang kena tahu waktu korang stres tu apa coping mechanism yang korang akan buat waktu tu. So it is good for you to practice a good coping mechanism. Contohnya waktu stres dia akan pergi jogging. Dia a good coping mechanism. Okay, ataupun pergi shopping ke, ataupun pergi makan dessert ke. So salah satu coping mechanism yang especially korang kena basically kena apply self-love lah, self-care. Yang tu lah bagus lah untuk korang in future sebab korang rasa medical school ni stress tau, tapi waktu korang kerja lagi lah mencabar benda tu. Lagi menguji lah. Okay. That's all for me today, and this is my reference, which is the PG of Variability, PG non-variability, and also Oxford Handbook of Clinical Medicine. Okay, thank you. So he never promised this unit will be easy, but he promised that he will be with you every step of the way. Okay, itu je lah daripada akak untuk pagi ni. Ada soalan lain? Tak ada soalan ke? Semua orang ada ke tu? Hello? Oh, okay, so ada soalan. How do we ask about the acid rash in Malay? And why do we give antibiotic for variability? Okay. So kalau good questions. Okay. So kalau untuk acid rash ni, kita akan tanya waktu patient tu, dia selalunya patient akan ada pedih oleh hati. Lepas tu acid rash tu dia akan rasa masam-masam dalam mulut dia. Macam dia macam selalunya tak makan pun. Selalunya acid daripada perut tu yang reflux. Sebab tu kita panggil dia GERD, gastroesophageal reflux symptom. Okay. So acid dalam perut tu dia akan naik ke atas, and then dalam mulut dia tu dia akan kadang-kadang dia akan rasa masam-masam. Sebab acid kan dia masam. Okay, tanya macam tu lah, dia tak rasa masam-masam ke dalam mulut kadang-kadang tu waktu tengah sakit perut ke, waktu tengah pedih ulu hati ke, tanya macam tu. Lepas tu, why do we give antibiotic for variceal bleeding? Sebenarnya kita tahu the most common cause variceal bleeding adalah chronic liver disease. So chronic liver disease ni, patient tu memang dah dia dah kita boleh panggil dia immunocompromised lah sebab patient tu memang dah prone to infection. So kalau dalam patient yang variceal bleeding ni sebabkan dia CLB, kita selalunya memang akan cover dengan broad spectrum antibiotic. Sebab patient ni bila dia masa, bila dia bleeding, bila dia masa dia boleh go into sepsis. So kita bagi empirical lah antibiotic. Menjawab ke? Ada soalan lagi?